Interpreting an Electrocardiogram, a podcast guide. Welcome to our podcast, where we dive deep into the art and science of interpreting an electrocardiogram. This is a systematic, multi-step process that involves both keen pattern recognition and a thorough understanding of cardiac electrophysiology. Today, we present a comprehensive discussion, structured to be clear and engaging for our listeners. Core philosophy: an electrocardiogram is a graphical representation of the heart's electrical activity as it unfolds over time. While it does not directly depict the mechanical contractions of the heart, that is the role of echocardiography, it does reveal the electrical impulses that precede and regulate those contractions. Interpreting an electrocardiogram involves analyzing several key factors: heart rate, rhythm, axis, and the various waveforms present. The systematic 8-step approach in clinical practice. A standard 8-step method is used to ensure that no critical findings are overlooked. Let's walk through each of these steps together. Step 1. Rate. Begin by assessing the heart rate. A normal rate ranges between 60 and 100 beats per minute. Rates below 60 beats per minute are referred to as bradycardia, which can be normal in athletes or may indicate conditions such as heart block or sick sinus syndrome. Rates above 100 beats per minute are termed tachycardia, which can occur during exercise or fever, or may signal abnormalities like atrial fibrillation or ventricular tachycardia. To calculate the heart rate quickly, count the number of large squares between two R waves and divide 300 by that number. Step 2. Rhythm. Next, determine if the rhythm is sinus rhythm. This is characterized by a P wave before every QRS complex and a QRS complex after every P wave, with P waves upright in leads 1, 2, and AVF, indicating origin from the sinus node. If the rhythm is not sinus, further identification is required. Atrial rhythms such as atrial fibrillation, which lacks P waves and is irregularly irregular, or atrial flutter, which features sawtooth F waves, must be considered. Junctional rhythms have absent or inverted P waves near the QRS complex, while ventricular rhythms present with wide, unusual QRS complexes. Step 3. Axis. The axis refers to the overall direction of electrical depolarization through the ventricles. A normal axis lies between -30 and +90 degrees, with the QRS complex positive in leads 1 and 2. Left axis deviation, greater than -30 degrees, shows a positive QRS in lead 1 but negative in leads 2 and AVF, and is commonly caused by left ventricular hypertrophy, left anterior fascicular block, or an inferior myocardial infarction. Right axis deviation, above 90 degrees, displays a negative QRS in lead 1 and positive in AVF, which can result from right ventricular hypertrophy, pulmonary disease, or left posterior fascicular block. Step 4. Intervals and timing. Focus on the intervals. The PR interval, measured from the start of the P wave to the start of the QRS complex, should be between 120 and 200 milliseconds. A prolonged PR interval suggests first-degree atrioventricular block, while a shortened interval may indicate pre-excitation syndromes such as Wolff-Parkinson-White. The QRS duration, representing ventricular depolarization, should be less than 120 milliseconds. A longer duration could signal bundle branch block, a ventricular rhythm, pacing, or hyperkalemia. The corrected QT interval, which is adjusted for heart rate, is critical to assess. A prolonged corrected QT interval increases the risk of dangerous arrhythmias like torsades de pointes and may be caused by medications, electrolyte disturbances, or congenital syndromes. Conversely, a short corrected QT interval can also be pathological. Step 5. P wave. Atrial depolarization. Evaluate the morphology of the P wave. It should be upright in leads 1, 2, and AVF, and neither notched nor peaked. Abnormalities are significant. Tall or peaked P waves, greater than 2.5 millimeters, suggest right atrial enlargement, sometimes called P pulmonale. Wide, notched P waves exceeding 120 milliseconds, often M-shaped, point to left atrial enlargement, referred to as P mitrale. Step 6. QRS complex. Ventricular depolarization. Assess the amplitude of the QRS complex. Low voltage across all leads may reflect pericardial effusion, obesity, or chronic obstructive pulmonary disease, while high voltage often signals ventricular hypertrophy. Pathological Q waves, wider than one small square or taller than 1/3 the height of the following R wave, indicate an old myocardial infarction, representing dead tissue. Bundle branch blocks are important to recognize. Right bundle branch block presents with a characteristic rabbit ears pattern in leads V1 and V2 and a wide QRS, while left bundle branch block is seen as broad, notched QRS complexes in leads V5 and V6, with no Q waves and STT changes opposite the QRS. A new left bundle branch block is considered equivalent to a street elevation myocardial infarction. Step 7. ST segment early ventricular repolarization. The ST segment is crucial for detecting ischemia or infarction. Normally, it is flat and aligns with the baseline. Elevation of the ST segment is a key sign of acute myocardial injury or street elevation myocardial infarction and must be observed in specific territorial patterns, such as inferior or anterior leads. It can also be seen globally in pericarditis or in benign early repolarization. Depression of the ST segment indicates ischemia or strain, and may be horizontal, downsloping, or upsloping. Step 8. T wave and U wave. Ventricular repolarization. The T wave should be upright in most leads with a left-sided dominant pattern, particularly in leads 1, 2, and V3 through V6. Inverted T waves are normal in some leads, such as AVR, V1, and lead 3, but elsewhere they may indicate ischemia, hypertrophy, or strain. Tall, tented T waves are a classic sign of hyperkalemia or very early ischemia. The U wave, a small wave following the T wave, may become prominent in hypokalemia, bradycardia, or with certain medications. Putting it all together, pattern recognition. Experienced interpreters rapidly scan for critical, life-threatening patterns. These include street elevation myocardial infarction, which is identified by street elevation in contiguous leads, life-threatening arrhythmias such as ventricular tachycardia, ventricular fibrillation, complete heart block, and rapid atrial fibrillation. Toxic or metabolic conditions like hyperkalemia, which presents with peak T waves and wide QRS complexes, or prolonged QT intervals. Pericarditis, recognized by widespread saddle-shaped street elevation and PR depression, and pulmonary embolism, which may show sinus tachycardia, right bundle branch block, right axis deviation, and T wave inversion in leads V1 through V4, the classic but not always sensitive S1Q3T3 pattern. Important caveats and limitations. It is important to remember that a single electrocardiogram is merely a snapshot in time. A normal tracing does not rule out intermittent ischemia or arrhythmias, which may require continuous monitoring. Always compare the current tracing with prior ones, as old electrocardiograms are invaluable for distinguishing new findings from chronic changes. Clinical correlation is essential, since the same finding may have very different implications depending on the patient's age and presenting symptoms. Lastly, be vigilant for artifacts caused by patient movement, tremor, or poor lead contact, as these may mimic true arrhythmias. Conclusion. Interpreting an electrocardiogram is a fundamental clinical skill that combines systematic analysis with rapid pattern recognition. The 8-step framework provides reliability, while experience enables clinicians to immediately identify emergencies. This test remains one of the quickest, most cost-effective, and informative diagnostic tools in medicine. True mastery comes from studying thousands of tracings and always correlating the findings with the patient's clinical history. Thank you for joining us today. If you enjoyed this episode, please like, share, and subscribe. This is the Everything Surgery Podcast, where we dissect the extraordinary.